Hi, and welcome to another edition of Your Health with Dr. Christy. My name is Dr. Christy Reisinger, and today we'll be talking about a new outpatient therapy for COVID-19 that you'll start to hear more about. The hospital system that I work at has just announced that they will be administering IV antibody therapy called bamlanivimab, or BAM for short, for mild to moderate high-risk COVID-19 patients that are not hospitalized. I think we'll start to hear more and more about other states and hospital systems around the U.S. that will start providing this therapy as well. It's just been given the emergency use authorization by the FDA, and it's the only outpatient therapy that's been approved for COVID-19. Let me first describe who this therapy is for. There are very strict qualifications for it, and every qualification must be met in order to receive the one dose of IV antibody treatment. To qualify, you must be aged 12 years or older, weigh 88 pounds or more, have mild to moderate symptoms of COVID-19 for 10 days or less. You must be high risk to get very sick from COVID-19, and you can't be in the hospital or be using supplemental oxygen for your symptoms of COVID-19. Well, who's considered high risk? Patients that are 65 or older, those with obesity with a BMI greater than 35, someone with diabetes, chronic kidney disease, or a condition that weakens the immune system, or if you're aged 55 and older and have heart disease, high blood pressure, or long-term lung disease. The drug is given through an IV infusion for at least 1 hour. Now let's back up and talk about what antibody therapy is. Everyone may remember when President Trump received the Regeneron's antibody therapy last month. Well, now Eli Lilly Pharmaceutical has also developed an antibody therapy. Antibodies are produced by the immune system in response to bacteria, viruses, and other foreign invaders, and it helps the body to neutralize and destroy these threats. However, it takes time for the body to produce its own antibodies, and the hope is that administering an antibody engineered from a COVID-19 survivor can speed recovery from COVID-19. The science behind this approach is not new. In fact, the practice of using convalescent plasma, which is the liquid part of the blood that contains antibodies, has been used to treat medical conditions for decades. However, because convalescent plasma must be obtained from individual donors, it cannot be scaled broadly, and its effectiveness varies between individual donors. But now, advances in biotechnology allow scientists to quickly identify the effective antibodies from patients who have recovered from COVID-19, and now they're able to mass produce them. The Eli Lilly antibody therapy has been studied using a trial called BLAZE-1. I'll put a link in the description so you can read more about it. During the BLAZE-1 trial, which is a double-blind, placebo-controlled trial, researchers were testing decreased viral load, symptoms, and COVID-related hospitalization and ER visits in patients that received either a combination of 2 antibodies, which included BAM, plus another one called etesevimab, or a single antibody treatment infusion, which was the BAM antibody only. The New England Journal of Medicine published results from the one arm of the trial that included the BAM only and found that among 465 patients with mild or moderate COVID-19, 1.6% of people were hospitalized or visited the emergency room due to COVID-19 after using BAM therapy, compared to 6% of the patients on placebo, which corresponds to a 72% risk reduction. But the numbers involved are very small. 5 of the 302 BAM antibody recipients went to the hospital, compared to 9 of the 150 people on placebo. It's possible that the apparent benefit of BAM therapy will evaporate in larger studies. But in a post hoc analysis that was focused on high-risk subgroups, such as age greater than 65 or a BMI greater than 35, the percentage of hospitalization was 4.2% in the BAM antibody group and 14.6% in the placebo group. So these differences were much higher. However, this was just a post hoc analysis, meaning that this was just data obtained after the study was looked at. Based on this information, on November 9th, the FDA issued an emergency use authorization for bamlanivimab for the treatment of mild to moderate COVID-19 in adult and pediatric patients. Eli Lilly said it's waiting until later to request an EUA for the combination therapy while it accumulates more safety data and develops manufacturing capacity. However, a phase 3 trial called BLAZE-2 is now in progress with BAM monotherapy in nursing home residents and staff. At the end of the day, I think we will be seeing this infusion therapy more frequently, since it's the only medication with EUA for mild to moderate COVID-19 patients that are not hospitalized. But there are logistical concerns about who should get it and how it will be given. As we know, hospitals are very tight on space and nursing support, and someone that needs this medication will need to go to an infusion center. The key is making sure the staff are kept safe and the patients are kept safe too. This will take a lot of time and effort. Infusion centers currently typically treat vulnerable patients with cancer or rheumatological diseases that cannot mix with COVID-19 patients. So my hospital system is setting up infusion centers at specific hospital sites. Furthermore, timing is essential. The BLAZE trial ensured that patients received the BAM antibody infusion within 72 hours of a positive COVID-19 test. And so obviously, this is what will be attempted when it's used around the country. As the pandemic rages on, it will be interesting to see what data we obtain from this therapy as more people receive it, and whether specific COVID-19 infusion centers crop up around the United States. And while the thought of an outpatient treatment option for high-risk patients is a welcome advancement, it definitely comes with its own set of complications. Thanks again for joining me.